Dr. Qamar Masood is a section head at Aga Khan University Hospital, and he is like a very prominent national figure. Please welcome Dr. Qamar Masood.
Bismillahirrahmanirrahim. Thank you very much, Dr. Sobia and the other members to give me this opportunity to talk about hyperglycemia in hospitalized patients, and the emphasis is on the practical aspects. So the talk would perhaps be more tailored for our junior endocrinologists and our fellows in the audience. So we start with the name of Allah. Okay. So the objectives is hyperglycemia. Will discuss few points like hyperglycemia in critical care setting, associated morbidity and mortality, evaluation of current targets of glycemic control, and discussion on some insulin infusion protocols that are in use. I'll emphasize more on the review of the new guidelines in the non-critical care setting, and that will also cover steroid-induced hyperglycemia. So a patient gets admitted with hyperglycemia in the hospital. He might have a history of already have diabetes. He might have unrecognized diabetes, or it may be just stress-related hyperglycemia because of the acute illness. Okay. So hyperglycemia occurred in about 38% of the patients admitted to general medical and surgical wards. It's an old survey there. 26% already known to have diabetes, and 12% had unrecognized diabetes or hospital-related hyperglycemia. And it is associated with increased mortality. Non-diabetics had higher mortality when compared to the individuals who have normoglycemia, and patients who have new onset hyperglycemia or first recognized hyperglycemia have even higher mortality, 16%. And this is a study in the, you can see this arrow there that Crinsley has done this study published in Mayo Clinic Proceedings, and the level of blood sugars were almost directly related to the mortality in these patients. I think our surgical colleagues, particularly cardiothoracic surgeons, take the lead there in improving glycemic control, and they have this in the Portland. Prior to 1987, they were using mostly subcutaneous insulins as per sliding scale, and the goal was to keep the blood sugars under 200. And in 1991, they started using an IV insulin protocol with the goal to keep the blood sugars between 150 to 200 milligrams per deciliter. And we can see that after the introduction of the insulin infusion or IV insulin protocols, their rate of deep sternal wound infections declined dramatically after that. And again, the enthusiasm was there. Insulin as a metabolic therapy. Several observational studies have associated hyperglycemia as a predictor of mortality and infarct size in patients treated with perfusion study. Initial studies like DIGAMI study showed some reduction in the mortality with intensive insulin treatment. Later on, DIGAMI 2 and the other studies did not show improvement in the mortality, and perhaps the reason was these later studies were not able to achieve the glycemia. So it's rather blood glucose rather than insulin itself which was associated with improvement in the mortality and infarct size and other things. So this was a landmark study that changed the game in critically ill patients, and this is a single center study. They used a very strict blood sugar control in the intensive group. Their aim was to bring the blood sugars in the range of 80 to 110, and this was achieved by almost 100% patients were receiving IV insulin infusion. And in the conventional group, the goal was to keep the blood sugars between 180 to 200, and they were started on IV insulin when the blood sugars were above 210, and we can see that 39% were receiving IV insulin. So this change in the blood sugars in the both groups resulted in a significant improvement in the survival of these patients in the ICU, and not only survival, but it was associated with decreased incidence of sepsis, dialysis, blood transfusions, and even polyneuropathy. So a huge improvement, and it was published in a very reputable journal, New England Journal of Medicine. However, the critiques at that time, they have some critiques over there, and they were saying that the control group have a higher mortality, and they have an unusual practice of giving IV glucose of 200 to 300 grams on admission to the surgical ICU service. So ACE come up with the guidelines at that time in 2002, and they said that the blood sugars should be kept as close to 110 milligrams as possible, and generally less than 180 milligrams per deciliter in these patients who are critically ill. However, later the same group did the study in the medical ICU patients, and they did not find a significant reduction in the in-hospital mortality. However, morbidity was reduced, and in a subgroup who stayed in the ICU for 3 or more days, there was some reduction in the mortality. So then finally the NICE sugar study, it was a multi-center, multinational study in Australia, New Zealand, and some, I believe, in Canada as well. And to answer this question, whether we really need that tight intensive control in the of 80 to 110 in our ICU patients. Okay, and it was a nicely done study. You can see the both groups, the conventional group with the aim to keep the blood sugar between 140 to 180, and in the intensive group it was 80 to 110, and you can see that both groups are very clearly achieved these, and they were separated very nicely. However, the intensive group in this NICE sugar study showed that there is an increased mortality in the intensively treated group. And it was across, I have not shown there in the slide, but it was across whether the patients have new onset hyperglycemia or known diabetics, and all these subgroups. So all favor a blood sugar target of 140 to 180 rather than 80 to 110. However, a group between 110 to 140 is not studied. And finally, the ACE and the ADA come up with the new guidelines in 2009, and they said that a glucose range of 140 to 180 is the recommended target. However, targets less than 110 are not recommended. So how we can achieve this? It needs a continuous variable rate of IV insulin, should be easily ordered, effective, safe, easily implemented by the nursing staff, and able to seek blood glucose range via hourly blood glucose monitoring and adjust insulin to the insulin sensitivity of the patient. Yale come up with a protocol at that time, and it was very commonly used. It was using a blood sugar in the prior hour, a blood sugar in the current hour, and the insulin infusion rate. We at AQ also developed an insulin infusion protocol because the Yale was target to achieve a target around 110. Later on, they modified it to make between 120 to 160 range. So we at that time modified one of the protocols, and with the blood glucose therapy range to bring it to 140 to 180. So the protocol depends upon monitor blood glucose hourly during infusion, 3 main components: a bolus dose, followed by the insulin infusion, and then titration based on algorithm. So the bolus dose, the common method is if the blood sugar, for example, is 300 milligrams, you divide it by 100, you get a number of 3. So 3 units is the bolus dose that is given IV push, and the infusion is then followed by infusion, which is same as 3 units per hour as the bolus dose. And the titration is then based on an algorithm which uses current blood sugar, blood glucose, blood sugar in the previous hour, and the current insulin infusion range, which we call it X, factor X. So this is the modified protocol that we use. And this is the factor of X, value of X. So if the current insulin is like between 3 to 6 units per hour, then the value of X is going to be the 1. And then here it's going to change depend upon the blood sugar. So if the blood sugar, current blood sugar is between 220 and 250, and in the prior hour the blood sugar was in the same range 230, the protocol wants to bring it down to in the target range. So it will ask to increase the rate to 2x via factor X, so plus 2x rate. So if patient is using 3 units per hour, then factor is 1 here. So you will increase the rate from 3 to 5 units per hour. That's how we monitor. We developed an insulin calculator in our electronic health record system, so the nurses do not need to go to that chart. And we also developed some apps that are there both for Android as well as for the iOS system, and that app can help. It's freely available, and anyone can download as insulin calculator at AKU. We did study this, and it was published in the International of Diabetes in the developing countries. And what we achieved when we studied that is that blood sugar readings in the target range of 140 to 180, about 45% did achieve, 45% of the readings were in the range. Blood glucose readings in the safe range of 110 to 180, about 62%. Lower blood sugars like 70 to 109, about 5.3%. Hypoglycemia less than 70.4, like 21 readings of the 4,800 readings. And severe hypoglycemia, meaning less than 140, was only in 1 reading out of more than 4,000 readings. So now I will focus on management of hyperglycemia in the non-critically ill setting. Traditionally, we recommend basal bolus insulin regime for most of the patients who are hospitalized in the non-critical care areas. So 3 components: basal insulin, maybe in the form of twice daily NPH or once daily glargine or other newer basal insulins. Nutritional component, which is prandial component, and then a correction component, which is in addition to the prandial component. So 3 main components of the inpatient insulin regime. So for the sliding scale, the traditional teaching is it does not work. Reactive, not proactive. It let the blood sugar go up, and then it says give insulin. If the blood sugar in the normal range, in the targeted range, it says do not give insulin. And one size does not fit all. Oral hypoglycemic agents, many relative and absolute contraindications like renal insufficiency, liver insufficiency, IV contrast, pregnancy, and little flexibility. If you have given the dose of a sulfonylurea, then you can't take it back. So all these factors were there. But now these concepts have been readdressed in the new guidelines. So in 2022, last year, Endocrine Society has come up with the guidelines of management of hyperglycemia in hospitalized adult patients in non-critically care setting. So it talks about real-time continuous glucose monitoring. So they are saying the use of real-time continuous glucose monitoring with confirmatory bedside point of care testing for adjustment insulin dosing rather than point of care alone. So if it is available, and I was thinking about it, that perhaps in patients who are on IV insulin infusion, they are getting hourly blood sugar check, and in some of the private setups like our place, it becomes really very expensive, 24-hour blood sugars in 24 hours. So maybe a glucose monitoring CGMS would be cost effective there. However, certain precautions like acetaminophen, dopamine, vitamin C, hydroxyurea, that may interfere with the different systems. Now the guideline again asks the question whether when we are giving insulin, should we be using correctional insulin, which in our part of the world is called sliding scale, correctional insulin in addition to the scheduled insulin therapy, other words basal bolus therapy plus correctional therapy. Yeah. लेजर के लिए है, अच्छा, ठीक है. Or basal insulin with sliding scale. So that is the question the guideline asked. And so they are talking about if the patients are not on prior history, there was no prior history of diabetes, then initial therapy, if they have come up with hyperglycemia of more than 140, they are not known to have diabetes, then initial therapy with sliding scale alone can be started there. However, if these patients have persistent hyperglycemia, meaning they are more than 180, the addition of scheduled insulin therapy is suggested. Use of sliding scale alone and when to add fixed doses. So diabetes, patients whose diabetes are treated with diet or non-insulin diabetes medications. Initial therapy with correctional insulin or scheduled therapy is suggested. So the guideline is not saying one or not preferring one over the other because of the lack of guidance or evidence there. However, the goal is to keep the blood sugars between 100 to 180 milligrams per deciliter. In adults with insulin-treated diabetes, continuation of the scheduled insulin regime modified for nutritional status and severity of the illness is recommended. So now take it how we do it in our setup and what are the practical aspects. So I give an example here, a 60-year-old male with type 2 diabetes at home receiving premixed human insulin in the ratio of 70-30 with 30 units in the morning and 20 units in the evening, and his HbA1c is 10%. So on a premixed human insulin, not getting in good control, total 50 units per day, admitted with acute abdomen and made NPO by the surgical team. So how would you like to give that insulin? So our practice generally is, because he's on 50 units and not in adequate control with that, I would give 40% of the total dose as the basal dose. In other words, if you take 50 and you want to take 80% of that, that becomes again 40 units. Half of that would be 20 units. So if 50, 40% would be 20 units. So 20 units as a basal, followed by correctional sliding scale every 4 to 6 hours. Same scenario, now the patient admitted with decompensated heart failure responding to diuretics, now improving, not critically ill. Here I will use all three components of insulin regime, basal dose and bolus with the rapid acting analogs in the same ratio, 40 to 50% of the total dose divided in 3 meals, and supplemental correction factors. Now talk about glucocorticoid associated hyperglycemia. Should NPH be used versus basal insulin regimes be used for the patients with hyperglycemia receiving glucocorticoids? So an NPH-based regime may consist of NPH with or without prandial insulin, giving in divided doses depending upon the timing, pharmacokinetics, and frequency of a specific glucocorticoid being administered. NPH insulin may be added to basal bolus if patient is already on this regime. So for example, this is sometimes difficult, this statement is difficult to digest, but if, for example, if patient is coming to us basal bolus therapy and he has been giving like 30 milligram of the pred in the morning, then maybe just adding NPH in the morning with the same basal bolus therapy that he is receiving might take care of that hyperglycemia there. This does happens in our scenarios. For example, our chemotherapy patients, they are sent to us that this patient will receive once a week dexamethasone 10 milligram as a pre-chemo treatment, and in such scenarios we do use this additional NPH in addition whatever they were receiving at that time. There is a close monitoring needed and risk of hypoglycemia when the glucocorticoids are tapered abruptly. So take some examples here for the practical aspects. 59-year-old male with history of type 2 diabetes for 70 years, taking again 70-30, 16 units before breakfast and 10 units before dinner. So total 26 units admitted with acute exacerbation of asthma and aspergillosis. His glycemic control was poor with HbA1c of 10%. IV methylpred 40 milligram 8 hourly was started with further elevation in blood glucose levels. So we started with NPH 16 units before breakfast and 8 units at bedtime, and with insulin Lispro 8 units before each meal. So 24 plus 24, almost 48 units. At home, this patient was receiving 26 units. Blood glucose levels improve with titration in insulin dosages. Patient discharged home on pred 20 milligram with the plan of gradual tapering over 5 to 6 months. So on clinic visit, he was then shifted to a premixed human insulin, 36 units in the morning, higher dose because of the glucocorticoid, and 24 in the evening with metformin added, and his A1C gradually improved and his dose was tapered to 7.5 and the dose of insulin was decreased to almost 30 units per day. So patients receiving any type of supraphysiological glucocorticoid who are treated with a basal bolus regime require a higher percentage of nutritional or prandial insulin to achieve normoglycemia. Experts commonly recommended that pharmacodynamic profiles of insulin should match with the corresponding profile of the glucocorticoid. So here are some examples. For example, hydrocortisone is a short-acting. The hyperglycemic effects starts in an hour, peaks in 3 hours, and resolves in about 6 hours. Prednisolone, a commonly used glucocorticoid as outpatient. Onset of hyperglycemia is around in 4 hours, peaks in 8 hours, and lasts for about 12 to 16 hours. Now this profile matches with the NPH. Long-acting dexamethasone, it resolves 24 to 36 hours. So may need twice daily NPH there with prandial insulin to cover the hyperglycemic effects of dexamethasone. Okay, now the guideline talks about pre-specified preoperative blood glucose targets or hemoglobin A1C. They recommend HbA1c of less than 8% or a blood sugar in the range of 100 to 180 prior to a elective surgical procedure. And when it's difficult to achieve 8% because it will take some time, just having a blood sugar of 100 to 180 1 to 4 hours prior to surgery is also something which is considered. Receiving enteral nutrition in adult patients hospitalized for non-critical illness who are receiving enteral nutrition with diabetes specific and non-specific formulation, we suggest using NPH based or basal bolus regimes. I will deal it in with practical aspects of it. Continuous enteral nutrition, somebody receiving continuous IV like 30 ml per hour of glucerna. Basal insulin with correction doses of short or rapid acting every 4 to 6 hours is used. Dose of basal can be in the range of 0.2 to 0.5 units per kg. Intermittent feeding, like in our hospital, the common practice is 4 hourly, 5 feeds per day with a physiological break at 2 a.m. A small dose of basal insulin and rapid acting analogs before each feed. ठीक है, तो small dose, because now we are giving 5 times a rapid acting analog here and a small dose of the basal. 6 hourly feeding, we use a small dose of basal insulin and short acting before each feed. Non-insulin therapies versus scheduled insulin therapies. The guideline is not suggests that scheduled insulin therapy be used in the management instead of non-insulin therapies for glycemic control. Metformin, sulfonylureas, thiazolidinediones. DPP-4 inhibitors may be appropriate in select patients with type 2 diabetes and reasonable to begin other non-insulin therapies in stable patients prior to discharge as part of coordinated transition plan. So, in select adult patients with mild hyperglycemia like type 2 diabetes for a non-critical illness, DPP-4 inhibitors with either correction insulin or a scheduled insulin therapy can be used. Some practical aspects, linagliptin perhaps a preferred agent because it's through the GI tract is eliminated. So in even renal failure and liver failure patients, it can still be safe. And sodium SGLT2 inhibitors in patients with heart failure. That can be accommodated at the time of discharge or during even acute illness. I think I thank you very much for your attention here.